hablo un poco de español. So, I'm going to go to English now. Sorry. Try. Lección Z. I'm going to talk about non-invasive ventilation. Today, you can do non-invasive ventilation as small as this baby, weigh 270 grams, 24 weeks in severe smallpox gestation in baby. We compare the Coke can is 394, liquid Coke, Diet Coke is 355. This baby is very smaller than a Diet Coke, and now the baby is, so I'll show you the baby. So my objectives are, what are the different modes of non-invasive ventilation? How does it work? What are the different differences between the three modes of non-invasive ventilation? And finally, can we make it simple for these babies and for the families? This video is not working. So this is the baby. The baby was born at 70 grams and 24 weeks, and nobody could intubate the baby. So we started the baby on non-invasive ventilation, and eventually we intubated the baby. The video. So this is the most important slide for me to talk today. If you remember this slide, I'm done with my job. One, when you talk about when people say non-invasive ventilation, there are three clearly different types. CPAP, nasal CPAP, all of you know. It can be given with bubble CPAP or ventilator CPAP or using an infant flow driver. So all of them are the same. If you're using bubble CPAP in your unit, keep using it. If you're using ventilator CPAP, you can keep using the same. I'll show you data. No difference in terms of failures of nasal CPAP from one type to the other. Second mode is CPAP or BiPAP. It mimics CPAP. Why? Because it uses an infant flow driver. The higher pressure, peak inspiratory pressure, or PIP, that you can get is around 10. Sometimes, I don't know what model you have in Peru. In the US, we cannot go more than 10 on that. The European ones, you can go to 15 max. So the peak inspiratory pressure that you can get is limited by the high flow rate they use. Second, the depth of pressure, that is PIP minus P, is very narrow, 3 to 5 centimeters. And we have used there are two flow generators, one for the high pressure, one for the low pressure. And we have used a relatively long inspiratory time to deliver the pressure. So that is CPAP. The third one is NIPPV, nasal intermittent positive pressure ventilation. That is like invasive ventilation. It mimics invasive ventilation without an endotracheal tube. Use a nasal interface to deliver NIPPV. Why do I say that? Because it does require a ventilator. You can set any pressure you want, 20, 25, 30 centimeters sometimes to be used. So high pressure can be set by you, and the depth of pressure is typically somewhere between 10 to 25 centimeters. If you're on 20 PIP, 5 P, the depth of pressure is 20 centimeters. Right? So you can ventilate the babies much better. You can deliver larger tidal water. You have a higher depth of pressure. It is flow limited. You can control the flow and how much you want the baby to get. And you can use a relatively short exposure time. So I wanted to remember when somebody says NIV, you need to ask, okay, what type of NIV? CPAP, CPAP, or NIV. I know many of you, or some of you at least, use high-flow-nasal cannula. I do not allow high-flow-nasal cannula in my NICUs because the pressure generated during high-flow-nasal cannula is neither measured nor controlled by you. You have absolutely no idea how much pressure is generated. That's the reason we don't like to do that. wanted to remember, even on bubble CPAP, okay, it's a small study in preterm babies. This is the lowest flow at which bubbling was happening. Then they increased the flow rate without changing the depth of the tube in the water column. Still the CPAP pressure goes up. Even on bubble CPAP, pressure generated is proportional to its flow dependent. So they added 2 more liters and then 4 more liters. You can see the pressure went from 5 to 6 to 7 or 8 to 7 centimeters. Same way, this is the lowest flow at which you could watch the bubbling and then increase the flow by 2 or 4, the CPAP pressure goes up. So they concluded from this study that CPAP pressure is substantially flow dependent even during bubble CPAP. And it's going to be the same if we use high flow nasal cannulas. There are a number of nasal interfaces that we have to use to deliver any type of NIV, non-invasive ventilation. For example, drums, Hudson drums, nasal masks, or Inca drums. All of them are difficult to secure and causes more damage to the nose. Therefore, we developed a simple cannula to deliver CPAP or NIPPD. I'll talk about it at the end. So I have a simple question. Based on evidence of randomized controlled trials, nasal CPAP or CPAP, with or without surfactant treatment, compared to routine intubation with or without surfactant treatment, results in 1. Decrease in the composite outcome of death RPTD or no change in death RPTD. How many are thinking 1 is the right answer? Put your hands up. How many are thinking number 2 is the right answer? Nobody? No people. Okay. You can make mistakes here. So this is the compared to intubation with or without surfactant treatment, no decrease in death RPTD with CPAP or surfactant treatment. In other words, you can manage a baby on nasal CPAP, use surfactant by using insure technique or some other technique, and then you will get the same result as somebody who routinely intubates the baby. So we should not routinely intubate every baby with oxygen. That's what the study shows. However, nasal CPAP with or without surfactant therapy, they has not decreased the incidence of bronchopulmonary aspiration or BPD. Why? No matter where CPAP is done, which country, which part of the world, extubation failures or CPAP failures are much higher in babies, especially smaller babies. So the babies end up getting intubated or re-intubated. That's the reason you do not see a significant decrease in bronchopulmonary asphyxia in babies on nasal CPAP. So here is 4 major studies that have been published. Work from Morgan, 2008 from Australia, multinational study, support trial from the United States, very large number of babies, 1,316 babies randomized to CPAP or intubation. Another one, Oxford Network trial, published in 2011. Then South American Neonatal Network study, published in 2012. You can see the failure rate in CPAP is anywhere from 33.9% to 54%. So 1/3 to 2/3 of the babies fail. This is death or BPD. Absolutely no difference between CPAP and routine intubation. Smaller the baby, the smallest baby is 26 weeks, about 835 grams in the support life, has the highest incidence of death or BPD, 48% or 54%. Now, look at the failures of CPAP. There are 7 randomized controlled published, 2007 to 2012. This is CPAPs from 2007, Colin Marvin 2008, Rojas from Colombia 2009, Turpap from Italy 2010, support trial from the US, Vermont Oxford Network deliverable trial, Canada and the US 2011, and then South American unit network study. You can see in every part of the world, babies that were initially started on CPAP, failed CPAP sometime during their NICU stay and got intubated. That ranges from 1/3 to 2/3 of the babies. Smaller the baby, higher the failure rate. That is one of the reasons why they did not document or could not demonstrate a decrease in proper participation. So what happens if you start early CPAP in the delivery room or late CPAP? These are data from 11 studies in the last 12 years or so, from 2001 to 2012. And again, see, this is either data from Australia. He compared binasal prong versus uninasal prong. He showed that if you are going to deliver CPAP, use binasal prongs. Putting an endotracheal tube into one nostril, giving CPAP is not a good idea. Failures are much higher. You can see uninasal, 57% fail compared to 24% use binasal prongs in preterm babies to deliver CPAP. Second study compared infant flow driver to CPAP versus ventilator CPAP. Absolutely no difference in failure rates. Okay, CPAP failures. Another study from United Kingdom, bubble CPAP versus CPAP. No difference in failure rates. So overall, CPAP failures range from 20% to 80%. 80% is in babies, micro babies, 23, 24, 45 weeks. 80% of the babies fail CPAP, get intubated. What about CPAP? This is the largest study comparing CPAP versus nasal CPAP. Kripalani from Canada and multinational study. Babies less than 1,000 grams, less than 30-week gestation. 1,009 babies were randomized, published in the New England Journal last year. If you read the title of the paper, it says NIPP. Unfortunately, it's not NIPP. This is a study of CPAP versus CPAP. 46 weeks mean gestational age, about 800 grams mean birth weight. Look at the babies that were intubated after randomization to CPAP or CPAP. 60% babies failed and got intubated. And look at the caffeine. 80% of babies got caffeine in both groups. Survival PPD, absolutely no difference. 1/3 of the babies had bronchopulmonary dysplasia. If you look at delta BPD, again no difference. So if you are using CPAP and CPAP fails, don't waste your time going to CPAP. The failures are going to be similar. Okay? Because CPAP mimics CPAP. This is the largest study comparing these two modes of ventilation, not invasive. Why do babies fail CPAP or CPAP? Most common reason they fail is apnea, bradycardia, or desaturation. Apnea, bradycardia, or desaturation. That's the most common reason. Nearly 60% of the babies, and or the FiO2 is over 50%, or CPAP is more than 8 or 9 centimeters, or frank respiratory acidosis with a pH less than 7.2. So either apnea, hypopnea, frank respiratory acidosis is the most common reason in 91% of the time that babies fail CPAP or CPAP get reintubated. Even if you exclude that 80% from one study from San Diego, CPAP failures is randomized controlled trials range from 24 to 67%, right? I just showed you. So what can we do when CPAP fails? There are backup rates. So that is what we call it as nasal IMV, intermittent mandatory ventilation, or nasal IPPV, NIPPV, they're all the same, or nasal cannula IMV. So how does that work, NIPPV? One, when you use NIPPV, you are using higher pressure, therefore you cause more pharyngeal dilation. You reduce the upper airway resistance. When you inflate the lung, there is a physiological reflex called H-paradoxical reflex, which actually augments baby's spontaneous respiratory effort. You maintain a better FRC, functional residual capacity, because you are using higher mean airway pressure. Increase in tidal volume, because you are using much higher delta pressure. Your recruitment is better using higher mean airway pressure. Reduction in chest wall distortion and increased workup breathing. Plus, most important, you still have all the benefits of nasal CPAP. So when you change the baby from nasal CPAP to NIPPV, you still have all the benefits of nasal CPAP, adding to all the other benefits I just listed for the NIPPV. Now, let's look at how do we deliver NIPPV. One, you want to set the baseline pressure, now we call it as P, and then higher pressure, side pressure, peak inspiratory pressure. Duration of this high pressure, peak inspiratory pressure, has to be, inspiratory time has to be at least 4 to 5 times the time constant. Because when you deliver NIPPV using drums or cannula, the resistance is higher. Deliver the pressure you dialed in on the machine, you have to use at least 0.5 seconds inspiratory time. You always use 0.5 seconds. Number of cycles or rate, you have this a higher background rate. You cannot start a baby on the rate of 1, you will fail. Start at a higher rate of 40 is typically what we do. I will show you some data, that 40 may be better. And then flow rate. If you have an older ventilator, you have to dial the flow rate. Sometimes you may need 14 to 16 liters per minute, but then you put in the flow sensor, what goes to the baby can be high. It is a study, small study, looking at CPAP of 5 centimeters, and then NIPPV, 10 over 5, 12 over 5, or 14 over 5. As you increase the peak inspiratory pressure, the workup breathing is reduced. Okay? Inspiratory workup breathing or resistive expiratory workup breathing or resistive workup breathing. I don't know why the slide is off the projector needs to be I can change it. So most of the data is here. So ventilator level peak inspiratory pressure during, this is a synchronized NIPPV, which is in the capsule, shows decreased workup breathing. That's why if we want to be successful with NIPPV, we always start 20 over 5 or 20 over 6. And then based on the baby's response, we increase or decrease the peak. This is a small study from Bangalore group in Miami, where they looked at synchronized versus non-synchronized versus nasal CPAP, and they also showed this study that at the rate of 40 breaths per minute, every time the machine cycles, esophageal pressure, baby doesn't have to work hard. So respiratory unloading is much more striking if you use a higher rate during NIPPV. That's the reason I tell you that you should use a higher rate. So we start at the rate of 40, as I mentioned before. Okay. If the baby is breathing spontaneously, you see how much harder the baby has to put. Negative pressure in the esophagus during spontaneous breathing, whereas every time the machine cycles, baby doesn't have to work on hard. They concluded that respiratory unloading was much more striking, higher background than NIPPV. So let's look at the data. Yes, they're all nice. Let's see what the data shows, right? There are 9 randomized control studies that have been published comparing nasal CPAP versus NIPT, either as a primary mode or if you have been intubated for some time, you decide to extubate the baby, then babies are randomized to CPAP or NIPT. We first published the first paper in 1999. And then this study from San Diego, Philadelphia, Israel, Morati from Rome, Kishore from India, Milan, South America, and again back in the US. Every single study showed the green bar is NIPT, the red one is nasal CPAP. Every one of them. If you manage a baby on NIPT, failure rates requiring intubation or re-intubation is significantly lower. The highest incidence that reported was 25%. And that is in this study by 2 women from Israel. 25% of the babies killed. Everybody else somewhere between 5 to 15. So significantly less extubation failures in the NIPT compared to nasal CPAP. No question about that. You can see 1, 2, 3, 4, 5, 6, 7 of the 9 studies show statistically significant decrease in extubation failures NIPT compared to nasal CPAP. What about longitude? Again, bronchopulmonary dysplasia is reported as a secondary outcome in all these studies. Again, you can see there is a trend towards less BPE in the NIPT group. Here is a Kugelman study from Israel, Bandari study from Philadelphia, and a Rome study from the multi-center in the US. 3 of these studies, there is a statistically significant reduction in BPD based on NIPT compared to nasal CPAP. Again, secondary outcome. So nobody has done using BPD as a primary outcome compared to these 2 modes of ventilation. Clearly, there is a trend on the other studies. So what happens if we combine early surfactant therapy using an insure technique? Intubation, surfactant, extubation. That's the insure technique. And then randomize the babies to CPAP and NIPT. This is the only study that we know of. We enrolled 110 patients, and then we gave surfactant to babies less than 30 weeks with a diagnosis of RBS. And we extubated them to CPAP. The failure rate in mechanical ventilation while the endotracheal tube, 7 days of rate, significantly lower, 17% versus 40%. Any time in the NICU, extubation failures, 23% compared to 58%. We looked at secondary outcomes, physiological BPD, or after 36 weeks, significantly lower. Being a baby with RBS, who receives a surfactant and then managed on NIPT compared to nasal CPAP. There was no increase in the need for second or third dose of surfactant. In this case, we used it. So I think based on evidence, NIPT, which mimics invasive ventilation, has been shown clearly associated with much lower extubation failures and a trend towards decrease in BPD compared to babies who are intubated and managed with or without surfactant. Now the problem is this. Whenever you have baby on nasal CPAP, these are studies using nasal CPAP. So in this NICU from Ohio, every day an ENT specialist came and looked at the babies. And they graded these babies' nasal trauma, that this is normal. Little bit of ulceration, there's a granulation tissue, 35% blockage, 50% of the blockage, or another necrosis. Necrosis this part of the nose. So be very, very careful when you are doing non-invasive ventilation, especially in the microbreaths. You cannot put any pressure on the septum or on the column. So they reported 5.5% incidence of columnar necrosis on a baby on CPAP just after 12 days, and 13% incidence of granulation tissue or blockage of the nostrils. Another study from Stuttgart, similar report. You can see a little bit of redness and then became a little bit more ulceration and a deeper ulceration, damage to columella. They reported 20 to 60% incidence of nasal trauma during CPAP or CPAP. So that's the reason we designed a simple nasal cannula to deliver time cycle, pressure limited, intermittent mandatory ventilation. We have now treated over 600 babies for over 6,000 days of NIPPV. We call it as nasal cannula IV, but it's pretty much the same. And only had 4 cases of transient nasal injury. None of them are permanent. We follow these babies up to 1 year of age. We repeat the hearing stream and follow the upper airway anatomy. We have not seen any nasal injury. As I mentioned before, we have used from 270 grams to 4 kilos. Failure rate, 8%. Required intubation. What about in the delivery? We all go to bag and mask ventilation, right? However experienced you are in the delivery room, mask leak, upper airway obstruction was very common. This is a study from Melbourne, Australia, where they showed that mask leak and airway obstruction are very common in very low birth weight babies during initial resuscitation in the delivery room. So we decided to use our same technique of this modified nasal cannula to use for primary DNA resuscitation. So this study we published in February of this year, the American Journal of Perinatology. So we looked at, so when we go to the delivery room, we put this nasal cannula close to the baby's mouth, attached to a T-piece or a neopod. Based on CPAP, the baby is not breathing well, we give a ray using our finger, the NIPPV, and then move the baby to the NICU. It's the bag and mask ventilation. We use T-piece cannula for resuscitation. We are not currently doing a randomized control trial compared to this technique, bag and mask ventilation. Typically do in the NICU, in the delivery. So these are some of the guidelines we use for NIPPV or nasal cannula IV. As I mentioned before, we start with peak inspiratory pressure of 20 centimeters, 3.5. The FiO2 is high, or chest exhalation of lung is not well expanded. We increase the peak to 8. Rarely we go to 9. We always start with an inspiratory time of 0.5 seconds. And the rate of 40. I told you why we use higher rate, why we use a longer inspiratory time, why we use higher peak inspiratory pressure. How do you wean the babies off NIPPV? So when the FiO2 is less than 40%, PCO2 is in the normal range, pH is okay, 7.25 or so. We first decrease the peak inspiratory pressure, then decrease the speed, 4 or 5, then only decrease the rate. Wean the rate last. Once the babies are on a peak expiratory pressure of 10 or 15, peak of 5, rate is 10 or 20, we transition the baby to nasal CPAP, and then after 24 hours or so, we go to low flow cannula, and then take the baby off. Practical issues are when you are using CPAP or CPAP or NIPPV or the nose. Every time somebody looks at the baby, we call it as nose rounds. So everybody that looks at it, nose round, check the baby's nose, make sure the cannula is not touching or the bombs are not touching. If they are, wash your hands, move it down, retape it, so it doesn't get pressure. These babies are on NIPPV for weeks. Especially a 14-year-old baby, maybe on 6 weeks. Therefore, you wanted to make sure you're not putting any pressure. Sometimes you put a door down, something keeps the pressure off the columella for the months. When fixing the nasal cannula, make sure that there is a gap within the columella and the nasal cannula. The other thing that we do, baby sick, you intubate the baby, leave them invasive ventilation, conventional or high frequency, babies are getting ready to be weaned. Babies are getting ready to be weaned. What do? We put the babies back on conventional ventilation. It's a bad idea. Extubate the baby, high frequency ventilation. 2, non-invasive ventilation. Okay, that's what we do. Once the babies are stable on the oscillator or on the jet, they are on low settings, you are thinking about changing to a conventional ventilation, we do not. We extubate the baby to non-invasive ventilation. That's typically what we do. 20/5, the rate of 40, inspiratory time for 45 seconds. So, my summary slide. Start in the delivery room with NIPPV or nasal CPAP. Continue NIPPV in preterm babies until about 13 weeks. Especially the babies are having apnea, bradycardia, desaturation. Don't switch them to CPAP because they end up getting intubated for the babies. So keep the babies on until about 33 weeks and then low flow cannula. Where do we go? The future, if you synchronize non-invasive ventilation, is nice. We don't have a very good way of synchronizing NIPPV. For example, neurally adjusted ventilatory assist or NAVA is a very good way of synchronizing. It's very expensive, doesn't work that well in microbreathing, so we only use NAVA in one of our units. And then you can also, there are case reports of non-invasive high-frequency ventilation. We have done so far 10 babies. Babies that failed NIPPV, instead of intubating them, we put them on high-frequency ventilation. And there are case reports published on nasal high-frequency ventilation. I'd like to thank you all for your attention. These are some of the babies from different parts of the world that are receiving NIPPV. Thank you for your attention.